All right, folks, let's do it. Good morning, all. Welcome to ASA. Thanks all for being here. I'm Rick Dutton. You can see all the stuff here. I have a couple of different jobs. I'm a site chief at a University of Maryland hospital on the Washington, D.C. Beltway. I'm a chief quality officer for U.S. Anesthesia Partners nationwide. I've been around the business for an unfortunately large amount of time. This is a new lecture project we're starting this year. Those of you who read the ASA Monitor regularly know that about a year ago we launched a series of case vignettes from the Closed Claims Project. Once a quarter we put one in. There's a committee that generates those, and several of them are represented here today. And as the next step in that, we're taking it on the road, so bringing it here. So many of you know, I hope most of you know the Closed Claims Project and what it is. Started at the University of Washington, and still a lot of the intellectual capital is there. I don't know if Karen joined us this morning, but Karen Domino is the current godmother of the project. We all owe her a great debt to keeping it going. It is a registry of cases, now over 10,000 of them, starting in the early 1980s, that are abstracted from insurance company records, malpractice carrier records regarding anesthesia. So the way the process works, ASA has contractual arrangements with many of the large malpractice carriers. We try and hit all of them. Once a year or so, we will send a team of anesthesiologists, trained abstractors, to sit in the insurance company building so the records never leave their place, and look at closed malpractice claims that involve an anesthesia issue. There's a very long, as we can attest, form that goes with looking at each case, but that then loads the data into the registry in a de-identified way. So all these cases are, first of all, out of the legal system. They're closed because, believe me, the carriers won't let us look at them until that's true. And then the information is abstracted in a blinded fashion into the registry. And dozens of papers have been written out of the Closed Claims Project. It's been a very rich contribution to our history of safety. So the first one was, what do people get sued for in anesthesia? Circa 1990, the answer was airway. It led to a lot of changes, a much more heightened focus on airway management for our profession, and we have reduced that risk over time. That's the kind of thing that the Closed Claims Project contributes. Scientifically, there's a long disclaimer that goes with every published report from Closed Claims. It says we have no idea what the denominator of this data is, right? There are obviously lots of biases in who gets sued and why, but it is an excellent snapshot at any given moment of exactly what I just said, what costs us money in the malpractice system. So in general, the Closed Claims Project is a good take at any given moment of what are our biggest potentially most expensive issues. So this morning's project, 4 speakers will each go for about 8 or 10 minutes, talking through specific cases. All of these have been published in the Monitor, and you can look there to see the details of them. We'll just crank through the 4 presentations. I think you'll find them interesting. We all have a certain sense of schadenfreude about this kind of thing. There but for the grace of God go I. And then we'll take questions at the end about any aspect of this you find interesting. So here are the agenda and the speakers. I'll let each of them introduce themselves and their specific site and disclaimers and so on. You've already heard mine, and I will get us kicked off. So the specific presentation. So this is an increasingly common practice model today in the United States. It's a small orthopedic ASC, 2 rooms. In this case, a solo anesthesiologist providing hands-on, one-to-one care for a patient in this center. 39-year-old woman, morbidly obese, was probably the most significant risk factor, coming for a shoulder arthroscopy. So this is a pretty routine case to this point, and you probably have in your ASC BMI limits for what you accept. Maybe you've done it the way we do, where you have a black, don't go there, a white, no problem, and a gray area in the middle where you discuss it with the surgeon in advance. But in any case, this case did not seem unusual for this site or center. Patient had had some cardiac workup, as you can see, normal, normal, normal. All right, has an uneventful induction intubation, lateral position, 30-minute procedure, and toward the end, all of a sudden, a very abrupt leap in the blood pressure. You can see 225 over 125. So the anesthesiologist, this is that moment when you suddenly need 8 arms to do everything you need to do. Increased the anesthetic, gave some labetalol, hypertension persisted, they aborted the procedure, turned the patient supine, and then over the course of a few minutes, very rapid fall in blood pressure, getting to PEA. So no palpable pulse, CPR, epinephrine, did after a few minutes achieve return of spontaneous circulation and was transferred per the institution's protocols to the hospital. Here's the run out from this. So I don't know how many of you have seen a case like this. I actually have fortunately in the main hospital recently, something very similar. Gets to the real hospital, has an echo, which demonstrates global hypokinesis and an EF of 30%. Transferred again to the university hospital downtown, and the patient, to make a longer story short, recovers. Has a cardiac cath somewhere out there, and the ultimate diagnosis, as you can see, is Takotsuba cardiomyopathy from intraoperative hypotension. A lot of retrospective looks at cases, particularly if you're looking at insurance records, depositions. You know, we have some of the primary source material from the EMR. You have the reviewers from the Closed Claims Project can look at deposition testimony, fact witness statements, and so on. Best anybody can reconstruct, probably the patient got either rapid uptake of epinephrine from the shoulder capsule or a direct intravascular injection by the surgeon. And that's what precipitated the event. And then I suspect most people are familiar with the physiology, sudden strain on the heart, and it fails. This is the broken heart syndrome, named for the Japanese lobster pot, hence the name Takotsuba. And it is a temporary, transient, and largely reversible sort of instant heart failure. All right, and that's what's believed happened to this patient. Treatment when it does happen to you, as I say, I saw a case of this recently, probably precipitated by anaphylaxis. The patient does check out rather quickly and rather completely. We echoed that patient in real time. The heart was not moving, but over a few minutes with epinephrine CPR came back, and then the next day nothing's wrong. And it's the weirdest thing ever, but it does happen. So that's the physiology. I picked this as a case to write up for the Monitor because there are some very interesting features to this that are very characteristic of anesthesia practice today and something that we're all grappling with. So more than 50% of our work nationwide is now outside of what we think of as the traditional hospital OR suite. Some of it's in the same building, in the GI lab, pulmonary EP, radiology, and a lot of it is in freestanding buildings in our community. And this has been a major and rather rapid demographic change. I remember working in the first ASC in 1990-ish, and since then, they're everywhere. Staffing these sites is a challenge. Obviously, Amanda and I were just talking about the economic implications of this. It's very hard to staff a 2-room surgery center efficiently, so it consumes a lot of wasted anesthesia time. It's one of the things contributing to our workforce shortage right now is the fact that we're very spread out. We're very horizontal as a specialty, and that's inherently inefficient. A lot of new models out there right now. I've been having some of these talks with my hospital system. There are obviously many surgery centers across the country that have only CRNA coverage. There are some where there might be a doc and a CRNA, but they're in 2 separate rooms, each doing their own thing. There are some where you might have bigger surgery centers with a lot of CRNAs and 1 doc covering a lot of rooms. All of these are in play right now in the real world across the country, and they produce interesting quality and safety challenges, obviously. But the big one and what I'm focused on here is you don't have enough hands and minds when you have a real emergency, right? The plane can land and take off by itself today, and really for the last couple of decades, but you still have a pilot in the cockpit in case one of the red lights goes on. And that's how anesthesia is going to look for the foreseeable future. We'll have target-controlled everything. We'll have auto-drive anesthesia, both infusion pumps and the machines, but we deal with complicated patients. We're constantly pushing the envelope of that, and the short version, stuff is going to happen. So it did in this case, and it becomes a real challenge for that single anesthesiologist, no matter how well trained and well experienced, to do everything you need to do all in 1 second. And that's basically the problem here. So how do we prevent this, or how do we mitigate it going forward? Pick your cases carefully. I already mentioned the sort of white, gray, black, right? If you're going to be in an austere environment, and that's what an ASC is an austere environment, you want to be there with carefully screened patients that you know you can take care of well. You obviously have a different threshold for risk. In my trauma center, you basically can't be too sick to go to the OR, right? We're going to do everything. You know, if it's urgent enough, you have to do it, and we'll accept that risk, and everybody gets that. But in an ASC, you don't want to be pushing that envelope for exactly this reason. Obviously, you want to have the site prepared. My business nationwide, we have a checklist. Every time we take on a new ASC, our quality director will go there with the anesthesiologist, walk the site, where is the code cart, show me the protocol for transfer, how are we screening patients, et cetera. And there's a very defined checklist before we walk into any center. Just this last month, we've added difficult airway equipment to that after a couple of bad events, but now there must be a glide scope with a hyperangulated blade, you must have a bougie, you must have a disposable laryngoscope, et cetera. You must have LMAs of the right size. And then finally, and why we're here and why this is a good case to discuss, is the cognitive element. Recognize when you're in that situation, recognize the difficulties. If you've thought through it ahead of time, you'll have some idea of how to respond in the moment. And then there are some things you can do to help. You should have the crisis app on your phone. Stanford just released a new version of it this week. It's free. You can download it. Something equivalent should be on your phone or on your EMR. Know who to call for help. So one advantage of being at an ASC, but part of a larger practice, is there are people you can talk to, either in the moment or when you see the moment coming, right? Hey, would you do this case? How would I manage this? What do you think is safest? And this is our starting point for our discussion today. This is a typical example of what the closed claims project looks like. I think it went by. Let me go back a couple slides. Yeah, here we go, the bottom of this slide. So this anesthesiologist did everything right, given that they only had 2 hands and not 8, but the documentation was poor, because that's one of the things they didn't do while they were doing CPR. Okay, and as a result, the case ended up settling. So this ended up costing the anesthesiologist and the center some money because they couldn't prove that the care was correct, that this was unpreventable, all right, and that they had done everything they could. All right. So with that, I will leave off. We'll go get the next one. Let me find the next. Richard, you're on. Let's get you up here.
All right, well, thank you so much for joining us today. So in my presentation, I would like to cover several representative cases related to wrong side, generally related to regional anesthesia performed on the wrong side. So let's see. So we'll talk briefly about that. Again, we have about, 8-10 minutes, some representative cases and key learnings and future directions. I just want to set the stage, kind of what we know about wrong side. This is the latest report from the Joint Commission looking at wrong side surgery with different subtypes. It's freely available. It's really, really very interesting, very informative. But you can see that wrong side accounts for 68% of all what they call wrong surgeries. And if you look at the trends for the last 5 years in the right lower corner, over the last 5 years, we're still seeing about the same number, give or take, of sentinel events related to wrong surgery. The most common contributing factors, and we'll get back to that later in the presentation, obviously policies and procedures. You'll see these sort of same themes as we go over these types of cases. Timeout not performed or was incomplete, and lack of shared understanding or mental model across the entire team. So no surprises, right? This is a paper that I published with my group. It was published in the Joint Commission Journal using closed claims. These were not ASA claims. It was data from the doctor's company. But nonetheless, this is the first paper of its kind, as far as I know, looking specifically at wrong side surgery and closed claims. And hopefully it's easy enough to see, but just looking at table 4, top category, so cases that are more likely to result in wrong-sided procedure. Again, this is specific to anesthesia. It would be things like spine surgery and peripheral and orthopedic surgery, right? So again, no surprises there. You have other services, urology, general surgery, hand surgery, and so on. But those are the most common. Spine, so different level, wrong level, or usually regional anesthesia for one of the orthopedic procedures. So I have 3 cases. They're all very similar, but I think they're just helpful for us to kind of understand what are some of the precipitating factors in these cases. So this was a 71-year-old female. The plan was for left, so what I have in bold is the correct side, left total knee surgery. The anesthesiologist decided to place a left femoral catheter for post-op pain. Asked the patient which side it was being done on, and the patient said the right side. So she specifically really said the wrong side. It was noted that the left side had been marked, but was covered by a sheet. And we see this, people just don't focus more on things that are exposed versus areas that are covered. And they just automatically assume it's the one that's uncovered, that doesn't have the IV on that side. That's the side I want to do a block on. Well, without checking all the proper documentation. So it was covered by a sheet. Operative consent was correct. It said the left side, which is the correct side. In the holding area, it was noted that the right-sided catheter and a left-sided marking was present. And so surgery consent marking was correct, and the catheter was basically placed in the holding area preoperatively. The interesting thing is you'd be like, how can this happen? But I've seen it in sort of the research that I have done and published. When when patient was asked, the patient basically said, I know, I have no idea, whether it was pre-medication or whatever happened. So the catheter was removed, surgery was done the following day without difficulty. Let's go back. So that's case number 1. Second case, left foot, correct side, bunion surgery, 55-year-old. So patient was given 2 milligrams of midaz after she was seen by the anesthesiologist. And anesthesiologist saw the patient, got consent, gave her 2 milligrams of midaz, came back 40 minutes later, set up the block, and patient was flipped prone, and the right leg was uncovered. So again, that's sort of the first error that happened. So obviously wrong side. Patient was asked to raise the leg while being prone, to be blocked, and raise the right leg. The anesthesiologist asked the nurse if the right leg was the correct leg, and the nurse also confirmed the wrong side. Block was performed. Surgeon arrived and was upset because the wrong leg had been blocked. The other leg, the correct leg, the left leg, was then blocked as well, and surgery on the left foot was performed. So 2 blocks in this case, the right block, wrong block, and the correct block. Patient sued the anesthesiologist, alleging nerve damage to the right leg, which is the wrong side, from the block. Injury was never confirmed, and the suit was dismissed. So that's the story. And one final one, 58-year-old female, arthroscopy, ACL repair under general anesthesia was the plan. Again, the correct side was the left side, and it was marked in the preoperative area. Surgeon, so this case, it was the surgeon who performed surgery on the wrong knee, on the right knee. And the interesting is about the circumstances why this happened, right? And so both the anesthesiologist and the circulating nurse in the ambulatory, so this was a surgery center, had seen the marking on the knee. So surgeon and the anesthesiologist and the nurse actually noticed it, and it was marked correctly. The OR staff had set up, what happened was the OR staff had set up the surgery for the incorrect side with all the instruments that were needed for the procedure, right? So the surgeon walked in and it was just set up on the wrong side, and the surgeon assumed that that was the correct side. And so did the anesthesiologist. The anesthesiologist assumed the setup was on the right side and performed right femoral block on the OR table. Patient was anesthetized, timeout was performed. The surgeon made an incision on the wrong knee, which was the right knee, and surprised that the ACL looked good, but repaired it anyway. What are you going to do? Mistake was not noticed by any of the staff when the patient woke up. So unfortunately, it was after the fact. From anesthesia, pointed out the error to the recovery nurse. Informed the surgeon, the anesthesiologist. Reported significant knee pain and limitation in activity on the side that was operated on, which was obviously the wrong side, wrong knee. Basically was a clear error, and it was settled for obvious reasons. So again, some learnings from this. Again, 3 cases, very similar themes, different circumstances, of course. When we see nerve blocks, again, that just based also on closed claim studies, on the work that I have done with other similar databases, procedure timeouts, right? So sometimes inadequate, poorly done. Not all people who are involved, not all team members participated. Checklists were either inadequate or used incorrectly, or incomplete use of those checklists. Patient positioning, as you can see, to sort of, other than supine, if they're turned on their side or prone, that is definitely a risk factor for these types of things. Confusion, limited visibility when the patient is turned and under the drapes. Again, what's exposed, what's not, and people make assumptions about the correct side. And sometimes, clearly, patients will give you the wrong information. So lack of multidisciplinary team training is something certainly my institution undergoes routinely, is really, really important. And of course, not following policy protocols, whether it's the sign-in or some other things, consenting and how things are done, checking all of the things before even bringing the patient in to make sure they are correct and consistent. Possible solutions, some are obvious. The question, really, the key is it's all about implementation, right, and buy-in and constant auditing of these things. Culture of safety, effective communication, including the patient in these conversations is really, really important. I think it's obvious, yet in these cases it didn't always happen. Or when it did, there were assumptions made that the patient, would give you correct information. Standardization, of course, and fully engaging all team members in these timeouts. Really easy for people to get distracted with other things, EHR or something else happening, other conversations. We all have seen this, right? Really important to just get everybody kind of focused on those timeouts and conversations that need to happen among team members. And then there are a couple of cases, that some I didn't show you just in the interest of time. Some controversy, obviously, about placing blocks in adults under general anesthesia. These are adult patients, and certainly risks, medical legal risks, not just injury, but also potentially not engaging the patient in this process. And of course, you're all familiar with the Swiss cheese model, but really good demonstration, and not in a good way, of kind of how things fail along the way and we get to that unfortunate outcome. Here's my email if you have any questions, and thank you for inviting me.
All right, next up, Dr. Young. Get his stuff going. There you go. All right. The best provocative title of the day.
Yeah. Patients on fire, everybody's worst day. This is a different kind of closed claims problem, because this is something that should never occur. I'm a cardiac anesthesiologist from St. Louis. Today we're going to talk about the causes and risk factors for fires in the OR, and we'll talk about the medical legal implications. I'm going to present two cases. First one is resection of a neck mass at a ambulatory surgery center, and it's done under MAC. This patient was a 65-year-old woman, pack-a-day smoker, COPD, not on oxygen at home, but heavy pulmonary involvement and a host of other problems. The anesthetic planned was a MAC with oxygen face mask, and when asked, the anesthesiologist said because of the COPD, but it probably could have been done with other oxygen or even no oxygen. This was after the Joint Commission's recommendations that there be a specific fire timeout, and they performed this, and it was noted to be a level 3 high-risk fire because head and neck locations are more high-risk procedures. Cautery was going to be used and oxygen. All of that makes it high risk. The procedure was performed uneventfully, with the exception that the surgeon didn't talk to the anesthesiologist, and the anesthesiologist didn't know what was going on in the field. As they were prepping, after the timeout, as they were prepping to go forward, the surgeon decided to, quote, test the cautery. So he sparked, and then he did it again for good measure. Needless to say, a fire started in the drapes, and it was immediately noticed. It was immediately doused with the mandatory bowl of saline that the scrub nurse had on her table. The drapes were removed, the oxygen was turned off, the oxygen mask was removed. Patient slept through the whole thing and was completely unaware of the event. The surgery was canceled. They assessed the patient, and she had a nickel-sized second-degree burn on her forehead, and some of her hair was singed. And she didn't remember a thing. She was transported to the affiliated emergency room by ambulance, and they saw her and discharged her later that day. She made a full recovery from the burn and had no problems. However, she did die of her comorbidities about a year and a half later, which is only important because that was after the lawsuit that was involved with this was underway. So the lawsuit started with the patient as the plaintiff and ended with it as her family. There was the obligate lawsuit. The thing about fires are, because they are never supposed to happen, you can virtually guarantee that there will be a lawsuit anytime you have a fire. The settlement for the procedure was no indemnity for the CRNA or the anesthesiologist, but their corporation that employed them paid $12,000. Legal expenses were $10,000, and in essence, this was the best possible outcome you could have. The second case is a semi-elective tracheostomy, a little more complicated. 46-year-old, 640-pound Pickwickian, known difficult intubation, full beard, OSA and BiPAP at home, had an ejection fraction of 20%, BiV pacer, the whole business, and he was getting progressively more short of breath, either because of URI symptoms or congestive failure. They weren't sure. So they were doing a semi-elective tracheostomy. The plan from the anesthesiologist was to avoid both awake and sedated intubation and to perform a trach under straight local with topical anesthesia and use BiPAP through the procedure with oxygen supplementation, and the backup was going to be fiber optic intubation. The patient was sedated incrementally over 15 minutes with 4 milligrams of midazolam, 100 mics of fentanyl, and was relaxed but awake and talking. Both physicians were completely focused on their own needs and did not communicate how things were going. So the surgeon made the incision uneventfully. Everything was going fine. The anesthesiologist had planned at that point to turn down the oxygen, but he actually wasn't aware that the surgeon had made the incision. So he did not turn down the oxygen. Remember, the oxygen was BiPAP, and the guy has a full beard, so it was obligate leaking oxygen. Not surprising, when the surgeon went to use the bovie, a fire started in the drapes. The patient's face was singed and burned. The BiPAP was immediately removed. It was doused with the saline. Oxygen was discontinued, and the patient was fine. But you now had an open neck incision on somebody who was on room air, and no real way to alter that because now you had burns all over the face. They chose to go ahead and proceed with the tracheostomy under local, and fortunately it was uneventful. They virtually just decided to write the patient a check at the end of the case. That's not true, but that was functionally what it was. And they settled for $10,000 from the anesthesiologist, a relatively small indemnity. The implications of this are that fires are very important. As we'll talk about in a second, they're actually increasing in terms of the number of claims that we're seeing now. We're seeing it more frequently, even with the institution of the mandatory fire timeouts. We well understand the fire triad, that you need oxidizer, fuel, and an ignition source. The oxidizer is frequently our involvement. The oxygen levels are our responsibility. The fuel can come from anybody. It can be from the PrEP solution. It can be from the drapes. It can be from the oxygen tubing for the mask or other stuff. It can be anybody. The ignition source is almost always the surgery. This is considered by JACO a never event, requiring fire timeouts, as I've said, and full awareness of the situation. The Closed Claims Project wrote a good review on the topic 12 years ago now. Summarized, this represents more than 650 cases per year, and it's increasing. It's 1.9% of all surgical claims. It's 4% of anesthesia claims, and it's 31% of MAC cases, and the most common increasing number is in older patients. Electrocautery was the igniter more than 90% of the time, and that too was on the rise. Oxygen was the oxidizer. 95% of the time it was open oxygen, that is a standard or a non-rebreather face mask or nasal cannula, as opposed to an intubated patient. The fuel was oftentimes the PrEP solution, and that's why we have the mandatory timeout to make sure that the solution is okay. Payments are much more frequent than in other claims, but with lower indemnity. That's what we saw there. 51% had failure to reduce oxygen, and substandard anesthesia was found in much higher frequency than in other claims. We've already talked about the Joint Commission and the lessons that they found. They apply in this case just like they did with the wrong side surgeries. These are the references, and the take-home point on this is the APSF has a wonderful website on OR fires and very graphic videos and things. Thank you.
Thank you, Kit. I've had a couple of endotracheal tubes ignited in my career. It is a very scary moment when that happens. And that is, both were tracheostomies where the tube was in situ, obviously with oxygen running through it, and the surgeon hit it with a bovie and it caught fire. That leads to a complicated moment. Last but not least, Amanda is going to talk about situational awareness.
Good morning, everyone. Thank you all for being here. As we've sort of all said, the Closed Claims Project really reflects our, as anesthesiologists, sort of pursuit for better understanding of where we can do better, which is such an essential element to the pursuit of excellence, which I assume we all are aiming toward in our care, and that our curiosity about how to make this better, how to make things better, is really such an important part of why this exists in our specialty, where other specialties really have not understood this in the same way. And I'm incredibly honored to be part of this committee, to be part of this group, hoping to tie a little bit of what we've talked about together with the discussion of situational awareness. Which is I'm sure you've all picked up, is a theme that really could have been helpful for all of the things that we've talked about. I have no conflicts to disclose, so hopefully we'll be able to describe situational awareness, really talk about its relevance in our practice, outline potential factors that could lead to gaps, and then really talk about strategies to improve all of this. And unfortunately, there are far too many cases that highlight this issue. One of them I'm going to talk about is a 29-year-old who had a submental salivary gland abscess, caused some difficulty swallowing, and there was a determination to drain the abscess. The patient was induced with propofol, succinylcholine, lidocaine, fentanyl. Direct laryngoscopy was performed. They were unable to see the cords. They asked for the glide scope. Wasn't in the room. People didn't know where it was, didn't know how to get it. Called the code, started CPR. Asked the nurses to bring a cricothyroidotomy kit. Same, didn't know where it was, how to get it. Somehow, the nurses were able to find the difficult airway cart and bring it forth. And cric was performed. The surgery was completed. Unfortunately, the patient has subsequently passed away. 29-year-old, perfectly healthy person. This may seem like it took an awful long time. If you look at the timeline, it didn't. And in many ways, they reacted quickly. They did things well, fast, after the sort of initial horrible event. You can see photos sometimes of what people look like. She didn't have this obvious difficult airway, but I can feel all of you thinking, oh my God, this abscess, what's up with this airway? But if you look at the timeline from 1850 to 1910, that's 20 minutes to get a cric in, start CPR, and start running a code in the midst of not being able to find the different things and sending people to go find things. This case highlights well, unfortunately, issues around situational awareness. So situational awareness is something, like many other things, we've borrowed from other high-hazard industries, particularly the military. A lot of our work comes from what the military has done on this, and it's the perception of elements in the environment within time and space, the comprehension of what those elements mean, and then projecting them into the future. Obviously, it involves cognitive tasks. This is obviously dynamic. Obviously, everything we do in anesthesiology is very complex and very dynamic. Conditions can change minute to minute. And then there's obviously several levels of processing that have to move forward. The military has further defined situational awareness into these levels. They've taken those elements of the definition and determined that level 1 is an awareness of the information. So in our world, that's, what do you know about the pre-op? Have you seen the echo? Have you seen the stress test? Have you seen the latest EKG? What do you know? What available information is there? And what do we know about it? What monitors do we have, and are we even looking at them? What's the comprehension of its meaning? So in our world, that's diagnosis. Are we taking in that information, and are we diagnosing it correctly? And a couple of my colleagues have already alluded to the idea of either perseveration or fixation or confirmation bias, where we take in information and we keep assuming that it's confirming what we've thought, except what we think is not correct. And so we really have to keep questioning ourselves, have we made the right diagnosis? Have we taken the time to think this through? And then projection of a future state. So this is anticipate and plan. So when a couple of you groaned at that rapid sequence induction, you were anticipating and planning. You were thinking this airway could be really horrifying. Why am I doing this in this way? Why am I not doing this in some other way? So for situational awareness, some of the elements that we've identified when we've gone through claims in the closed claims database is perception of the elements. What is the information? So one of my colleagues talked about a MAC, anesthetic, and saturation problems, blood pressure problems. Are we looking at the monitor? Are we understanding what's happening? Are we getting involved in extraneous details? And then for diagnosis, are we appreciating that the hypotension and tachycardia may represent some occult vascular injury, may not just be dehydration, may not just be reaction to the propofol? And for projection of their status, what is likely to occur? You may have a patient, you conduct a carotid endarterectomy as the case, and you start the case, and the patient's airway is perfectly normal. But now you're bringing that patient back from the PACU because there's bleeding. What's that airway apt to be like now? What's happened in the intervening time? Is that the same airway that you took care of this morning, or is that different? And so obviously making a plan based on that. When we've looked at the different cases where situational awareness is a factor in the closed claims database, there were about 198. As Dr. Dutton said, we really don't have the denominator, but we found 198 that were reviewed out of the thousands of cases that ultimately get reviewed. And 2 anesthesiologists reviewed them, looking at the different errors. Most of them, the most common element was that 75% of those cases involved situational awareness errors. And that is a very similar factor and figure to other high hazard fields. When you look at aviation, when you look at the military, when you look at nuclear power, 75% of errors involve situational awareness. Respiratory failure was most common. And they were also more likely to result in payment than other claims. 85% of those cases resulted in payment on our behalf or against us, either through jury verdict or through settlement. There seems to be something juries understand about this, that it makes a lot of sense to ordinary people, that we should have had all the information. We should have looked at the monitor. We should have understood. And if a payment was made on our behalf, the median payment was in the $500,000 range. We've heard some numbers today that are far, far less than this. This is a very significant number. It's certainly alarming. The most common were perception errors, and then comprehension and projection errors were roughly equivalent after that. So what are some options and opportunities that we can take? Well, sort of what I say to residents getting ready for the board. Every case. Are we thinking about what could happen? Are we thinking about if these monitors go awry, what could that mean for us? Are we really taking time to perceive and consider all of the different cues that we're getting from all of the different circumstances? Are we explicitly training our residents to better understand this, to better appreciate this, especially in what has become a much more fast-paced world where we're doing many more cases with far less time between them than we ever used to? And are we providing different training in pattern recognition? Really better understanding, if these elements go together, how do they go together? A couple of people mentioned the Stanford Cognitive Aid. Those are great teaching tools for anybody who's in a teaching program to work through with your residents. They're as good teaching tools as they are in an emergency, and there is some data that if we use them when things are not bad, we might actually pick them up when things are bad and have better familiarity with them. And so that is, I think we're up to questions.
All right, excellent, Amanda, thank you. Invite Dr. Young back up here. And yeah, now it's Q&A time. So happy to take questions about any of these cases in particular. If we know the answer, we'll answer or make it up. And or about the closed claims project in general. Yes, sir.
Hey, Ron Bank, Inova Fairfax Hospital, Northern Virginia. That was awesome. A quick question regarding that. It's concerning when you see this issue with the documentation during a code. I mean, obviously, no one's documenting during a freaking code, right? So, I've been doing the game a long time, like you guys have, but I generally write late entered note. Like, I'll just go at the end of an event. Once it's done, I specifically say late entered note, and then I write a narrative. I don't know. I mean, you can't do it in real time, and I would assume that people. I mean, obviously, you can't do it in real time. I would assume, even God forbid, you're in a jury situation. You want your doctor sitting there charting or treating. So interested in that.
Yeah, I'll start, and then I'll ask the panelists for comment. So, absolutely correct, right? The first thing they teach pilots in a crisis: fly the plane. Same thing applies to us. Take care of the patient first, and I strongly emphasize with my residents. The documentation will always be there. What you describe is exactly correct, and that is an error that the doctor made in this case, is they didn't write a complete note afterwards. Presumably they could have taken the time to completely describe everything they saw, what they did, what they were thinking, and it may well have helped their case in this. I hope, one of the things I'm looking at in my practice now, we're just starting to pilot this, we get to an era where a lot of our documentation is passive, right? We don't have to do anything. The drug doses are being recorded. Alexa, 50 of rocuronium, right, is going in the chart that way, whether through video, audio capture, obviously your EMR capture of vital signs. I would like to think that by the end of my career, a lot of the documentation burden is off us, and we can focus more on the patient in real time. We'll see. That's aspirational. You guys have comments?
I actually spoke with a malpractice attorney about just this issue, a few of them, because we decided as a group that we would set up a program with somebody to call in the group when something happens, to kind of look at the record with you, walk through things, think about what you might document. There's a time limit. If you go back to the chart within the next couple of days, that's one thing. If you go back to the chart within a week or two, that's a very different thing. So obviously, the sooner you can go back to the chart and really remedy what you've done, walk through it with somebody who isn't emotionally involved with that situation and can just kind of see, hey, you didn't record the Twitch monitor. Hey, this isn't all the different things that don't get automatically populated, that are just perfectly waiting to trip us up, to just kind of walk through those things. Because that seems, from the malpractice attorneys I've communicated with, they exactly know where we fall down in documentation, and they look immediately for those things.
And I would argue then the opposite of that, things that were automatically recorded, make sure you look at it. And if you disagree, there's a way to make a comment. Obviously, you don't want to delete things that have already been recorded, but there's ways to comment on each individual data point, essentially. That could be very kind of time consuming, but at the end of the day, you know, to kind of explain what actually, you know, what this number means or doesn't mean. I think it's important. So it's both,
Absolutely.
without deleting things, obviously. But
I would say that it's worth its weight in gold. However, you have to be careful. Earlier is much better than later. And you have to make sure that you are not setting up a chart battle between you and whoever else is going to be charting, especially if they chart later. So you really have to be explicit about what you're charting and what the care that was given is. The last thing you want to do is have a direct conflict with what the nurses in the operating room or the surgeons in their notes or whatever. So try to just keep it as accurate and as close to the time as possible.
Thank you. Yes, sir.
Hi, Alan Rosenberg. I'm in South Florida, also practicing a long time. I was wondering if there's any work being looked at on the airway catastrophe side, the catastrophic results. You know, we're in an era now where people kind of uniformly use video laryngoscopy and maybe don't understand some of the concepts of varying types of airway adjuncts and maybe have skills with them. I'm shocked when I have a lot of young providers coming on board how they're very laxed on those potential airway evaluations. You know, just going to just use a glide scope, no problem. And I don't find that there's both the skill set or more importantly, the observation that this can present as a problem when your one technique kind of goes down. And I'm wondering if we're seeing a trend in maybe a resurgence on claims on airways.
I wouldn't say a resurgence. What I would say is a constant. And like a lot of safety in anesthesia, one of the things that's very hard to measure and can be very discouraging if you look at it wrong, you know, why aren't we making progress on fires or wrong site surgery or airway disasters, is that as we make things safer, we reinvest that in harder cases, more urgent procedures, more difficult patients, bigger operations, what have you. So there's this, to some degree, we operate to a constant level of safety, a constant outcome, right? By, you know, and every time we exceed that in the safety direction, we find somebody sicker to take care of to push us back. So the 600-pound patient's a perfect example of that. 20 years ago, you know, no, we're just not doing that operation, right? So we don't even have the opportunity for that error. And so that's part of the answer. The skills question is fascinating, right? I think we'll take a poll. How many of you, for your ICU or ED intubations, glide scope first 100% of the time? Yeah, right? So that's kind of the standard of care out there now. Certainly if I'm teaching ED docs, if I'm teaching the intensivists who are doing occasional intubations, or if I'm running up to the ICU myself for a code, I'm just going to go glide scope first. We know that's safer, better, increases my odds of success. However, in the OR, how many of you are only glide scope in the OR right now? Very few hands, right? There's clearly the belief that we want our residents, that we want ourselves to have a broader skill set than that, to have a lot of different tools in the toolbox so that we can deal with the variations as they come up. And we'll get the other panelists' thoughts in a second on this. Do we reach a day where we don't do direct laryngoscopy anymore? Maybe. I mean, we don't spin our own hematocrits anymore. But I am a dinosaur. But but again, you know, the skills that go with direct laryngoscopy, the ability to use a bougie, the ability to do a airway assessment, to do a fiber optic intubation is important, and that is one. I think we are doing far fewer fiber optic intubations now, and I worry that that skill will be lost in my group, and that's one that you do occasionally really need, right? So I don't know, it's an interesting question. Panelists?
Go ahead.
I was just going to say, I would say that we're not making the old mistakes as frequently or as bad. We're making new mistakes.
Yeah, it's hard to make processes foolproof because the fools are so clever. That's the wrong site argument, because we've been battling that one forever, and you know, it may be that you just can't ever make it go away completely. I will say my comment on airways. I have seen a couple of surgery center difficult airway situations recently that worked out poorly. And again, one person, no equipment, no hands. And like I say, we've reacted to that by ratcheting up our training in that area, both in trying to avoid the problem, right? How to do the assessment so you don't do that case in the surgery center. And then also having we have a very basic rescue protocol, sort of a way cut down version of the difficult airway algorithm for how to get you out of that situation when it does happen in the surgery center. But I will say, again, I spent a long time in the trauma world, as many of you know. I have probably witnessed more surgical airways than just about any anesthesiologist in the country. I have never been sorry about doing a surgical airway, and it is far more likely that you will have regrets about being too late than about being too early. That's my take. Go ahead.
Hey, my name's Christina. I have not been practicing for very long. I'm kind of looking for a data point. I don't know if you have this in the closed claim project. I practice in the state of Vermont, where for many, many men, their beard is their most prized possession. And we know it's one of the, parts to difficult mask ventilation. And I have conversations with these men. I have to ask them, like, how attached to their beard are they, right? Because I may need to take it off. And you will be surprised how many men say, do not touch my beard no matter what. And so I'm just wondering, can you give me a data point that I can share with these patients to sort of make my case, that especially when they're obese and they have COPD and OSA and X, Y, and Z? Do you happen to have that? Can you give me some
data? Probably not, but I bet we got a lot of opinions in the room.
Oh, sure.
Start with the one right behind you. Go ahead, sir.
Now, one of the tricks that I picked up over the years, because I have been practicing quite a while, is to apply the largest tegaderms in the OR across the face and just slit for the mouth. That gives you a flat surface, not only for face mask, but it will also allow you adhesive for the endotracheal tube to stay in place and won't come off with time. I don't think any men who grow beard like that are anything but proud and don't want you to do anything but alter your technique for them, but you don't want to do it unsafely.
You'll be amazed. I actually did for one guy. I did that with tegaderms.
Yeah.
And I left it on for extubation because I wanted to be able to mask him afterwards. And he wrote me to the patient. Anyway.
You didn't like it.
No, that's why, that's part of your consent process. He had the beard when you got consent. You discuss everything about your management, and I leave no stones unturned, to the point that many of my patients say, I've never been interviewed preoperatively like you did, to anticipate issues like tape on the upper eyelid in women, false eyelashes, and so forth. But anyways, getting to the point, several of these cases suffer from lack of mock drills in ambulatory centers, whether it's the upper airway fire and the use of oxygen. Air should be your starting point, supplemental oxygen only if the patient's saturation is below 90. The airway, I mean, how can you have, I testify malpractice cases, ambulatory center where they couldn't find the crash cart for resuscitation of the patient. Same as your cricothyrotomy, you said, or the difficult airway. This should never be part of a malpractice situation or a medical legal situation, because every ambulatory site, hospital, so forth, should be doing their drills. And these all these examples are indicative of failure to maintain minimum mock practices.
I agree with that. No question. Situational awareness, right? This could happen here. What are we going to do? And I thought Amanda made an excellent suggestion, something I do routinely. You walk into the room, everything's fine, everybody's a little bored. Ask the resident or the CRNA, what's the worst thing that could happen right now? And then just play the game, all right? You know, what if the surgeon sticks the trocar in the aorta right this minute? You know, what if the patient has an anaphylactic reaction to the drug you just gave? What are you going to do? How are you going to do it? Play it through. That is enormously helpful. Doesn't require any equipment. It's the let's pretend game we've been doing since we were 3, and it can be an excellent way to build mindfulness in this situation. Yeah.
Great point.
Any other questions, comments? All right. Thank you all very much. Appreciate your being here.